Welcome back, everyone. We'll continue our respiratory section, and we are going to, as I mentioned, talk about two of the obstructive lung diseases that we have. We're going to start off with asthma. Some of you in this class may have had asthma. Maybe you still do. I better learn how to spell this, asthma. It's a very, very common condition, and it is defined as a chronic disorder that is characterized by recurrent episodes of airflow limitation. This is a really important catchphrase for this. Airflow limitation. And it's due to a couple of processes that are happening. Number one, it's due to hyperreactiveness of the smooth muscle of the bronchioles. And inflammation. So there's an aspect of hyperreactiveness that's causing the smooth muscle to contract. And there is an element of inflammation that's happening within the airways as well. And if you think back to our intro to pathophysiology, there was that idea of inflammation, including swelling of things. So if our airways start to swell, the diameter of the lumen is reduced, both by hyperreactiveness of the smooth muscle and by inflammation. So both of these things will limit airflow and inflammation. So it's important that there are both of these, hyperreactiveness and inflammation. The other really important aspect to this, and I'm going to put it in a different color because it's very important, this airflow limitation is reversible. In between attacks, if you were to treat it with something that can open the airways return to normal functioning. So it is reversible. Reversible airflow limitation. Really important way to describe it. The etiology is really unknown, but we know that it is in the category of allergic conditions. We know that there is a genetic component and an environmental component to it. And when somebody is predisposed to allergy, from a genetic standpoint, we refer to that as atopy or atopy. We talked about that in our section on hyperreactive, hypersensitivity reactions. And we went through the atopic triad. You should know the atopic triad. This includes the A's: asthma, allergies. These could be food allergies, environment, like hay fever, could be drug allergies, and atopic dermatitis. This is also referred to as eczema. While we don't know what exactly causes it, we do know that there are triggers that can actually bring about an allergic or an asthma attack. So the triggers for asthma are generally environmental. And there are a lot of triggers of asthma. Um, Allergens, so it could be dust, pollen, but also irritants to the airways. While some people are very sensitive to different scents, colognes, cleaners, people with asthma, it can actually bring on an asthma attack in them. So irritants might include scents, cleaners, cigarette smoke, cold weather, cold temperature, exercise can bring it on. Um, there's also one that's actually kind of interesting, chlorinated swimming pools. Tend to bring on asthma attacks, and it's not exactly because of the just the chlorine that's actually in the pool. It's actually a little bit more gross than that. When people swimming in swimming pools, they lose some of their skin. So there's human skin dander that's in the pool. So when you think about the mechanism of chlorinated swimming pools, there's human skin dander. These are just little skin flakes that come off. And when it mixes with the chlorine in the pool, it makes a volatile organic acid called trichloroacetic acid. This is a volatile acid that volatile means that it evaporates. And then when people are swimming in these pools, they're breathing in this acid, and it triggers the airways to become hyperreactive. And so this can actually trigger an asthma attack. Um, all right. The epidemiology of this is somewhere between 5 and 10% of the population have asthma. In general, age is a really important factor. When we look at the pediatric population, it is much more likely than adults to have asthma. Some people have asthma when they're growing up and then they grow out of it and they don't have asthma as adults, and that happens often. In the pediatric population, males are more likely than females to have asthma, but in the adult population, females are more likely than males to have asthma. We don't really know why that is. If we look at the actual pathogenesis of how and the pathophysiology and really the clinical manifestations of asthma, there is a clear path that occurs when somebody is exposed to an allergen or an irritant. So when someone's exposed to an allergen or an irritant, this is going to bind to a mast cell within the lungs and it's going to activate it. When a mast cell becomes activated, it's going to immediately release histamine. And we already talked about what histamine does to the lung tissue, specifically the smooth muscle. So there's going to be an increase in histamine, and that leads to a bronchoconstriction. And we know that this bronchoconstriction is going to reduce the radius of the airway. And that reduction in radius means that we don't get as good of airflow going from the lungs. So there is going to be this idea of airflow limitation. Remember that catchphrase of asthma, airflow limitation. The second thing that the mast cell is going to do is that it's going to induce the production of inflammatory mediators. So it's going to induce inflammation. This takes a little while longer. It's not immediate, but it does last longer. Inflammatory mediators and inflammation. And what this is going to do is it's going to lead to swelling. And one of the things that airways do when they become inflamed is they also release a lot of mucus. Mucus can clog the airways. It can sit in the airways and reduce the radius. And both of this swelling and the mucus is going to reduce the radius of the airways to the point that you get airflow limitation. So both the immediate effects of the histamine as well as the longer the inflammatory component that takes longer, both of those are going to lead to airflow limitation. Now, oddly enough, I'm going to explain this a little bit after. So with this airflow limitation, people have difficulty bringing air into and out of the lungs, and they feel short of breath. And the term we use for shortness of breath is something called dyspnea. Dyspnea. Dys means abnormal and pnea means to breathe. So abnormal breathing, shortness of breath. Because the airways are constricting, a lot of times people feel tightness in their chest. And air trying to leave smaller tubes with a smaller radius is going to have turbulent flow, and it's going to oscillate, and it's going to oscillate with a high frequency. That air is going to be all, it's not going to have that nice laminar flow of air. And this is going to be audible. And this audible sound that we get is something called a wheeze. So somebody's going to have wheezing. And this is an audible sound of air flowing across narrower airways during exhalation. So I would check for wheeze in people by getting them to take a deep breath in and then exhale forcibly. And I would listen to their lungs as they did so. And I would hear this whistling sound in people who have a wheeze. For reasons that are a little bit beyond our discussions today, in a normal airway, what you're getting is this is an alveolus. Air is going to flow into and out of it pretty easily. But in a narrower airway, air is going to have a much harder time flowing out. And when air tries to flow out and the airways are narrower, they tend to collapse when you're trying to exhale. And they close off even more, and it causes that oscillation to a higher degree. That's why we hear wheeze on exhalation. One of the most important things to check for, because asthma can be deadly if it's a severe asthma attack, we have to look for signs of respiratory distress in patients. Signs of respiratory distress. one of the things that people will do when they're having difficulty breathing is that they are going to recruit extra muscles to try to open their airways. They'll recruit the muscles in their neck. They're going to recruit mostly the muscles in their neck. So we call that recruiting accessory muscles to breathe. And you can actually see the muscles in their neck contracting. And when they contract, they actually try to open the airways. These tend to be neck muscles, like the sternocleidomastoid, the scalene muscles. One of the things that our body will do naturally to try to get air out is they will try to breathe through pursed lips, pursed lip breathing. It's a way to change the shape of the mouth to get the air to flow out better. People will have their nostrils will flare when they're when they're having difficulty breathing. So we have nasal flaring. One of the things that people will do when they're in respiratory distress is they will try to change their position by leaning forward with their hands on a table. And we call that tripoding position. It'll be tripoding. And then when respiratory distress gets really bad, when you're not able to move air into and out of the lungs and your oxygenation goes down, you start turning blue, which is a really severe sign of it. And we call this cyanosis. Cyan is a bluish color, and it's the condition of having this bluish color, and it's related to a severely depleted oxygen in our blood, decreased O2 levels. So it's a bluish discoloration. And where we look for this bluish discoloration is around the lips, fingertips, and under the tongue. Another thing that is really important about asthma is that people tend to get more frequent attacks of asthma in the middle of the night. The real question is, well, why at night do symptoms tend to be worse more frequently? And this actually brings in a really interesting piece of physiology that we haven't talked about yet. And there is an inflammatory component to asthma. So the reason for this is because with asthma, there's an inflammatory component. And we have an anti-inflammatory hormone that we produce naturally. And it tries to keep inflammation at bay. And this hormone is called cortisol. And so this acts like an anti-inflammatory. I am going somewhere with this. In order to understand why asthma symptoms tend to get worse at night, we're going to look at how cortisol is released in the body in terms of time frame throughout the day. So this y-axis is the concentration of cortisol in the blood. And we're going to look at from 8 in the morning, 8 a.m., all the way to the middle of the night. Cortisol follows a circadian rhythm. At 8 in the morning, we tend to get a spike of cortisol. And that cortisol is going to act as an anti-inflammatory all the way through the day. And it slowly goes down and down and down and down and reaches its lowest levels in the middle of the night. in the middle of the night, we have the lowest anti-inflammatory effect of our own cortisol. And that's why symptoms tend to get worse at night, because there is that inflammatory component to asthma. It is not suppressed by that cortisol at night because our levels are so low. This is also the reason why, think back when you've had a cold or the flu. You might feel fine during the day when your cortisol levels are very high. And then in the middle of the night, it seems like your cold just comes right back. You wake up in the middle of the night, your nose is stuffed, it feels awful. And it's because of that low cortisol that you don't have that anti-inflammatory on board as much as you do during the day. So when we think about treating asthma, we need to think about it in a couple of ways. The most important thing that a person with asthma can do is, TX is treatment. I should just write the whole word, treatment. But TX, if I ever use that short form, that's what I mean. The most important thing that a person can do with asthma is avoid triggers. That's going to avoid inflammation in the airways. That's going to avoid any attacks, but it's not always possible to do so. So the second mode of treatment are medications that can counteract some of the effects of asthma. So the second thing that we can do are to give bronchodilators. And these can sometimes act as a rescue inhaler. What I mean by a rescue inhaler is that it is used during an asthma attack. In general, these ones are in the form of beta-2 agonists. And they are short-acting. They're either short-acting or ultra-fast onset. But the one that is used typically is a short-acting beta-2 agonist. When you use it, it lasts for 4 to 6 hours. And it tends to be a short-acting beta-2 agonist. We often short form that to we call it a SABA, short-acting beta-2 agonist. And that's the lingo that we use in medicine. And the best example of this one is Ventolin. This is the blue inhaler. All the different inhalers that are used for the lungs all have different colors, and the color actually dictates exactly what is in it. The second thing that we use, and this is going to counteract that immediate hyper reactivity of the airways. The second thing is we have to counteract that inflammation as well. So we use anti-inflammatory. Now, I'm not talking about anti-inflammatories like Advil or Motrin or ibuprofen type medications, not that type. We're talking about the anti-inflammatory type medications that will mimic cortisol in the body. So they mimic cortisol. And these are in the form of inhaled corticosteroids. Sometimes we short form this to ICS, inhaled corticosteroids. These are not used as rescue inhalers. These are used regularly, usually twice a day. Used regularly. So i.e., not as needed. They have to be used consistently. So not you don't just take an inhalation of this when you're having an asthma attack. You have to use these twice a day, twice a day, twice a day, twice a day. The Ventolin inhaler you can take as a rescue inhaler. The most common one that's used is something called Flovent. And Flovent is the orange inhaler. Okay. There are other medications that we can use, but we will tend to use combination inhalers. So we will often use bronchodilators, ICS combos. Now, these bronchodilators that are with the inhaled corticosteroid, they're long-acting beta agonists because you'd have to use them regularly, not on an as-needed basis for most of them. There actually is one that you can use on a rescue basis, but most of these are used regularly twice a day. So this will include a long-acting beta agonist plus inhaled corticosteroid. The short-acting beta agonist we called a SABA. This we call a LABA. LABA plus ICS. One of the most important things, the reason that we don't actually see LABAs used on their own, they actually did some trials on this, and LABAs on their own increase risk of death in asthma. So we never use a LABA on its own. This is the reason that there are these combo inhalers, that we don't just give a LABA and say you have to take it with your Flovent. They put them together, so you can't take one without the other. So LABAs on their own increase risk of death. SABAs on their own are okay. LABAs on their own for asthma are not okay. Now, you'll notice that I didn't talk about how asthma is diagnosed, and there's a reason that I didn't talk about it yet, because in order to understand how it's diagnosed, you have to understand the treatment, which is weird. So the diagnosis of asthma is based on something called spirometry. They do these lung volume tests, and one of those lung volume tests is they check FEV1. And FEV1, because it is an obstructive lung disease, it's going to be less than 80%. Airways are obstructive. And in order to check to see whether it's asthma, you have to prove that this is reversible, that this change in FEV1, this reduced FEV1 is reversible. And the way that they do it during the spirometry is they'll check FEV1, and then if it's less than 80%, they give a bronchodilator. And this would be like Ventolin or something. Then they wait a few minutes. And then they check FEV1 again. And if FEV1 changes by greater than or equal to 12%, then there is a diagnosis of asthma made. So that shows that it's reversible. FEV1 improves by greater than or equal to 12%. Okay. The second obstructive lung disease that we're going to talk about is something called chronic obstructive pulmonary disease. This is called COPD. You can also call it chronic obstructive lung disease, and in that case, you would call it COLD. It's fine. I usually use COPD, but if you use the term COLD, people will know what you're talking about. This condition is defined as a progressive airflow limitation that is irreversible. So not only does it continually get worse once you're diagnosed with it, it is also not reversible. Chronic obstructive pulmonary disease consists of two conditions in one. Most people with chronic obstructive pulmonary disease have both of these conditions going on at the exact same time. So this is two conditions. One is called emphysema. The other one is called chronic bronchitis. This should not be confused with somebody being diagnosed with an acute bronchitis, or you go to the doctor because you develop a cough, you're coughing up some phlegm, suddenly you feel unwell for a few days, and you're diagnosed with bronchitis, you're given an antibiotic, it goes away and you feel perfectly fine. That is not the same thing as chronic bronchitis. Chronic bronchitis has a very, very specific definition. When we're talking about chronic bronchitis, that word chronic is really important. If you don't use the word chronic when you describe it, it does not mean COPD. If you just say bronchitis, it's not correct. It's specifically chronic bronchitis. And chronic bronchitis has a clinical definition. It is defined as 3 months of productive cough greater than or equal to 3 months of productive cough. What I mean by a productive cough is that you're coughing up phlegm. And this greater than or equal to 3 months has to occur for at least 2 consecutive years. Most people who have this don't just have a cough for greater than or equal to 3 months. They usually have the cough all year round, and it's for 2 years, and they're diagnosed with chronic bronchitis. That's the bare minimum that you need. 3 or more months of a productive cough for at least 2 years in a row. Emphysema is defined as destruction of the bronchioles This destruction in the bronchioles is going to lead to the airways collapsing and closing. And when the airways collapse, they actually get air trapped in them. The alveoli are going to look overinflated, but it's old air. It's not very good. It's not good for gas exchange. And they get air trapping. Air cannot move out. Most people have both of these conditions. When we look at the etiology of COPD, well over 90%, oh, I shouldn't even say greater than or equal, it's greater than 90% is related to smoking. Some COPD is related to air pollution. some COPD is related to people that have worked in the mining occupation for a long period of time. But those are minorities. More than 90% of all COPD is related to smoking. There is a genetic disorder that people can get COPD very early in life. It is very rare. I will tell you what it is. Small number of people have a genetic mutation. It's very rare. And the genetic mutation is for a particular protein called alpha-1 antitrypsin. And they have a deficiency of it. People who have this genetic mutation get COPD very young. Generally earlier than 40 years. And it is pure emphysema. There is no chronic bronchitis whatsoever. And it's very strange to have a pure emphysematous form of COPD. But that is ultra rare, like really, really rare. 90% of all COPD is related to smoking. When we look at the epidemiology of COPD, about 3% of the world's population has it. It is the fourth leading cause of death in adults. Generally, people are older than 40 years of age when they're diagnosed. If someone's under 40 years of age, you're going to look for that rare genetic mutation. Because most is due to smoking, we're going to look at the pathogenesis and pathophysiology related to smoking, the smoking cause of it. So smoking has a lot of irritants and chemicals that will lead to inflammation because it damages the airways. This is going to activate immune cells and those inflammatory cells. And recruitment. And the biggest, well, the most important cell to think about in COPD is the neutrophil. That's what's going to cause a lot of the destruction. When we look at it from a chronic bronchitis standpoint, this is going to lead to, this neutrophil is going to induce a state of inflammation in the airways. And this inflammation is going to lead to increased mucus production. And it's also going to destroy these tiny hairs that exist on the epithelial surface of the airways. Those are cilia. So it's going to destroy cilia. Cilia are really important in moving that mucus out of the airways. With destruction of those cilia, the mucus sits there and it's hard to clear it. And so this is cilia in the airways. And so what you get is decreased clearing of mucus. And what that does is it clogs the airways. And you guessed it, you get airflow limitation. airflow limitation. This decreased clearing of mucus, it's going to build up and build up. Eventually, you're going to cough some of it out and you're going to try to clear it out. And this will lead to a productive cough. So phlegm is going to be brought up often. When we look at the emphysematous form, I'm just going to put this in red here. The emphysema form, neutrophils in the area are going to produce proteases, enzymes that break down proteins within the body. They're going to produce proteases. And one of the effects of these proteases that are produced is that it's going to, one of those is an increased production of an enzyme called elastase. And what that does is it destroys the elastin in the bronchioles. And the airways will collapse. They lose their integrity. And air gets trapped. No air leaving, it leads to that airflow limitation. So both forms, chronic bronchitis and emphysema, both lead to airflow limitation. The difference between this compared to asthma is that this airflow limitation is irreversible. Even if you give a bronchodilator, it doesn't bring that FEV1 back to normal. A few more of the clinical signs of clinical manifestations. So that someone's going to have a chronic cough with phlegm, maybe shortness of breath. They may be short of breath all the time, and they may have an elevated amount of shortness of breath when they exercise. They almost certainly will. And because of that air trapping, if you do a chest x-ray on them, it actually looks like their lungs are hyperinflated because there's so much air that's trapped there. It's not that they have massive lungs, it's that they just have a lot of air that's holding up a lot of the volume and maintaining the volume of the lung. So they get hyperinflated lungs. So you can see this on a chest x-ray. It looks like their lung volumes are massive. You can also actually see it on people as well. They have this sort of habitus of their thoracic region that we call barrel chestedness. It looks like their chest is expanded, and it technically is because there's air that's trapped there. They also will sometimes have a lower oxygen content, and they will become cyanotic. If we try to diagnose COPD, we're going to do that FEV1 again. And it's going to be less than 80%. Did I put, wait, just go up for a second. Yeah, okay. It's going to be less than 80%. And you're going to give a bronchodilator. Just like we did for asthma. And there is no change. And what this does is it proves that it is irreversible. So once somebody is diagnosed with COPD. This disease is progressive. It gets worse. There is almost nothing that is known to change the trajectory of the disease course. It will get worse and worse and worse. Really the only thing, when we think about the treatment, that may offer some benefit at any stage is to stop smoking. That is the number one thing to do. All the medications that we use in COPD are for symptomatic treatment only. They do not change the trajectory of the course of the illness. So we are going to use very similar medications that we used for asthma, but not exactly the same way. So we are going to use bronchodilators. So we use those SABAs, like Ventolin, and it can be used as a rescue. We can also use, and this is a big difference with COPD, is that we're allowed to use LABAs on their own. For some reason in COPD, LABA use on its own does not increase risk of death. Okay, in COPD only. Now, I should qualify that. Okay, on their own. In COPD only. We also make use of another medication that is going to, if you remember what can change the smooth muscle contraction, also the parasympathetic nervous system could work as well to contract it. So when you activate the parasympathetic nervous system, those muscarinic receptors, that can cause contraction of the smooth muscle and bronchoconstriction. So we can block that. And we use something called a long-acting muscarinic antagonist. And these are called LAMAs. LAMAs. We can use combination therapies. Okay, we can use combinations. And we can use combinations with inhaled corticosteroids. I'm going to redo that word. I'll put it on the other line. Corticosteroids. Okay. Inhaled corticosteroids. So there's ICS. And good examples of those. So we can have a LABA ICS. So things like one's called Symbicort. That's good for asthma as well. Another LABA ICS is something called Advair. That's also good for asthma as well. We can also use triple therapy. There are medications that are LAMAs, LABA, ICS combos. One of them is known as Trelegy. And so that uses all three medications in a single inhalation. One of the things to note, just like asthma or similar to asthma, where LABAs taken on their own increase risk of death, in COPD, it's important to note that inhaled corticosteroids on their own are not used frequently because of an increased risk of pneumonia, and death. So it's interesting. In asthma, inhaled corticosteroids are perfectly fine on their own. We use Flovent. In COPD, they're not. They increase risk of death. In COPD, LABAs on their own are perfectly fine. In asthma, they're not okay. They increase risk of death. Okay? The other thing that we can do in COPD, and this is more end stage, is oxygen therapy. So hopefully this gives you a good overview the of the major obstructive lung diseases that are out there. This gives a little bit of a background of asthma from an allergic perspective, and also the fact that it's reversible. We also talked a little bit more about physiology and why asthma attacks are worse at night. That's a really important thing to think about. We went through the major treatments and how they counteract some of the clinical manifestations of asthma. And then we moved on to chronic obstructive pulmonary disease. We talked about the two different types, who gets it, how it occurs, what the main clinical manifestations are, how we prove irreversibility, and then some of the major treatments. So hopefully this gives you a good overview. As always, if you have any questions, don't hesitate to reach out, and I'll see you next time.